All right, let's jump right in. When you're dealing with blood disorders, things are almost never as simple as they look in the textbook. We learn a pretty basic rule, right? Low platelets mean bleeding risk, and thick blood means clotting risk. But what happens when your patient's body decides to break that rule? Today, we're going to unpack one of the most dangerous paradoxes in nursing, where a falling lab value actually signals the complete opposite danger you'd expect.
So, you've got these two extremes. On one side, thrombosis. That's the danger when blood gets too thick, too sludgy. And on the other, you've got hemorrhage, the danger when blood is too thin to form a clot when it needs to. Seems straightforward enough. But what if your patient's chart seems to be pointing to both at the same time? What's your priority action? That's what we're going to reason through together.
So let's meet your patient. This is Mr. Michael Alvarez. He's 64 and he's just been admitted to your floor. He feels terrible, and it's our job to start putting these puzzle pieces together.
Okay, so you've done your initial assessment. Let's look at the clues you've gathered. You have those general things, right? Fatigue, headaches, blurry vision, high blood pressure. But the real telltale signs are more specific. Take a look at his complexion. It's ruddy, kind of flushed. And this one, this is a big one. He says he gets this intense itching, especially after a hot shower. That's a classic sign. We call it aquagenic pruritus. All of these cues are pointing in one direction. His body is making way too many blood cells.
And sure enough, when his first set of labs come back, they confirm exactly what you were thinking. Check out his red blood cell count. He's at 6.8 million. That's well above the normal range. You can almost picture it, right? His blood is just getting crowded with all these extra cells.
Now, let's look at his hemoglobin. It's at 20, again, significantly elevated. And this isn't a good thing. It's another piece of evidence telling us that his blood is just far too concentrated.
And finally, his hematocrit. This number tells us what percentage of his blood is actually made up of red blood cells. Mr. Alvarez is at 58%. I mean, just think about what that means for his heart. It's working overtime, trying to pump what is essentially sludge through his veins. This really solidifies the entire clinical picture.
So, the diagnosis is polycythemia vera. It's a bone marrow disorder that kicks red blood cell production into overdrive. Now, here's the most important question for us as nurses. With blood this thick, what is the #1 most immediate danger we need to be ready for? Yep, it's clotting, thrombosis.
A patient with polycythemia vera is walking around with a ticking clock, basically. The risk for a major clot, a stroke, a pulmonary embolism, a heart attack, is incredibly high. So let's take a look at what happens when that risk becomes a reality.
So picture this. A different patient, Robert Chen, comes into the ED. He has a known history of polycythemia vera, and he's saying his arm feels weak and his speech is slurred. These are textbook stroke symptoms. His thick, slow-moving blood has almost certainly formed a clot that's now in his brain. This is the absolute worst-case scenario we're trying to prevent.
So, what's your first move? It's all about speed. Time is brain. You're going to do a rapid neuroassessment, make sure his airway is clear, and get him to that CT scanner stat. We have to see what's going on in his head. Then we manage his blood pressure and keep him NPO. Every single second counts here.
Okay, let's get back to our patient, Mr. Alvarez. Just as we feared, his thick blood caused a problem. He developed a deep vein thrombosis, a DVT in his leg. So we did the standard thing. We started him on a heparin infusion to treat that clot. And that is exactly when this case went completely off the rails.
Just look at the timeline here. Day 1, he's admitted. By day 3, he pops a DVT, and we start the heparin. For 5 days, everything seems routine, totally by the book. But then, on day 8, you get the morning labs back, and you see a new, really confusing and very dangerous problem.
You're looking at the results, and your stomach just drops. His platelets have absolutely cratered. They've fallen by more than 50%, from a totally normal 210,000 all the way down to 95,000. That's not just a little dip. That is a huge, clinically significant freefall.
So what is every instinct you have as a nurse telling you right now? Low platelets means bleeding risk. That's what we're taught. So the next step is bleeding precautions, right? Hold on, this is the critical thinking moment. You have to stop and ask yourself, is the obvious answer actually the right one here? It is not. In fact, it is the exact opposite. This is the great deception of this condition. While that lab number is screaming bleeding risk, what's actually happening at a microscopic level is that his immune system is making his remaining platelets go haywire. They're becoming hyperactivated, turning into tiny, aggressive clotting machines. This is called heparin-induced thrombocytopenia, or HIT. And that word paradoxical is the whole key. It's a crazy, life-threatening immune reaction to heparin. The body creates antibodies that don't just destroy platelets, they actually flip a switch and activate them, which triggers massive, widespread clotting.
To really nail this concept down, we have to compare HIT to a patient who is in a true bleeding emergency. Seeing them side by side like this will help you spot the difference out on the floor. So let's meet Linda Matthews. Her platelets are dangerously low, down at 18,000, and her body is showing it. She's got petechia, those little pinpoint red spots under the skin. She's covered in large bruises she can't explain. Her gums are bleeding when you do oral care, and she has melena, which is that black, tarry stool from a GI bleed. Her body is sending every possible signal for bleeding risk. This is what severe thrombocytopenia looks like, and it is the polar opposite of what's happening to Mr. Alvarez. Okay, so you've put the pieces together. You suspect HIT in Mr. Alvarez, and you clearly see active bleeding in Miss Matthews. What do you do first? Your next actions are literally life-saving.
For Mr. Alvarez, with suspected HIT, your absolute number one, first, non-negotiable action is to stop every source of heparin. I'm not just talking about the infusion. I mean flushes, coated lines, everything. Stop it all. Then you immediately call the provider, you keep watching those platelets, and you start assessing head to toe for any new clots, because you got to get ready to start a different non-heparin anticoagulant.
Now for Linda, our priorities are completely different. Here, our goal is all about injury prevention. We put her on strict bleeding precautions. Soft toothbrush, electric razor only, no IM injections, no aspirin or NSAIDs. We have to protect her from anything that could cause a bleed, especially a catastrophic one inside her brain.
So, let's just boil this all down one last time. In polycythemia vera, the danger is clotting because of thick blood. In severe thrombocytopenia, the danger is bleeding because of low platelets. But in HIT, the danger is paradoxical clotting. It's driven by platelet activation, even while the total platelet count is dropping. Knowing which danger you're truly facing changes everything.
And that brings us to the final and maybe most important point. The most dangerous assumption any of us can make at the bedside is that the obvious answer is the right one. A lab value is a clue, it's not the whole story. Real clinical judgment comes from connecting those clues to your patient and always asking why. So leave you with this question. The next time you're on the floor and you see an obvious sign, which one are you going to stop and question first?